Professor Ho for this highly scientific, elegant, and I'm sorry for the technical problems. And now our next guest speaker will be Professor Sahin. And she is the Director of Educational Operation and the Chief Breast Technology Department of Pathology, MD Anderson, USA. Her title for this presentation will be The Future of HER2 Testing with Special Consideration of Equivocal Results. Okay.
Am I going to open it? Okay. Good afternoon, ladies and gentlemen. First, I would like to thank all the organizers, especially Dr. Hesham El-Garazi, for inviting me. Which one? For inviting me back to this meeting. It's a great honor and pleasure for me to attend. And we're going to talk about HER2 testing in breast carcinoma with emphasis on equivocal results. Am I going to see the slides here? I cannot see it on the laptop. Okay. Now we have more than 2 decades of evidence that HER2 is a both prognostic and predictive factor in breast carcinoma. And HER2 overexpression and gene amplification can be seen in approximately 20% of breast carcinomas. Am I supposed to do something? And we have extensive evidence that HER2 targeted therapy has significantly improved the prognosis of HER2 enriched tumors in both adjuvant, neoadjuvant, and metastatic setting. And the response rates are so dramatic that when we talk about these trials, we have to talk about the pre and post HER2 targeted therapy eras. And there is one very important point that normal cells and all breast carcinomas express some HER2 at the low level. And then when we are talking about HER2-enriched tumors, we are talking about extreme presence of HER2 protein on the surface and gene amplification. And in breast carcinoma, more than 95% of the cases, the amplification is due to the protein overexpression. And because of that, the methodology that we are using for breast carcinoma, either gene expression or gene amplification or protein expression, can give you the same results. And now we have multiple different types of therapies for HER2 enriched tumors. And for all of them, the only biomarker that we have right now is the enrichment of HER2. Because of that, it is now critical to accurately determine HER2 status to maximize the benefit derived from HER2 targeted therapies while minimizing unnecessary adverse effects in the management of these patients with breast carcinoma. So what is the recommendation? Who do we need to test? We need to test all newly diagnosed invasive breast carcinomas and also all newly developed metastases. Use of anti-HER2 therapy in microinvasive carcinoma is controversial. In MD Anderson, we have some protocols, so we test even microinvasive carcinoma, but it's in the literature, it's controversial. Similarly, performance of HER2 testing on residual tumor after neoadjuvant therapy is controversial. Both ASCO and CAP wanted to have specific guidelines for HER2 testing and reporting, and the initial guidelines were published in 2007 and they were updated in 2013, and the panel did not really mandate selection of either IHC or FISH for first-line testing, but in United States, most of the laboratories use immunohistochemistry as the first line, and then all the 2+ cases are reflex to FISH testing, but there are some laboratories, they use the FISH testing as a first line and they use immunohistochemistry on selected cases. As I mentioned before, the protein overexpression is due to gene amplification. And ASCO and CAP, which developed the guidelines, recommend the results to be reported as either positive, negative, or equivocal. And now we're going to focus predominantly on equivocal cases. The definition of equivocal cases with immunohistochemistry was slightly changed in 2013 recommendation, and one of the main reasons for this change is not to miss any cases, calling them 1+. So the definition is circumferential membranous staining in within more than 10% of the cells, or complete and circumferential membranous staining in less than 10% of the cells. And the panel mandated that HER2 equivocal cases should have a reflex FISH testing. In this panel, you can see the 0, 1+, 2+, and 3+ cases, and these represent less than 20% of all breast carcinomas. If you look at the metastatic tumors, they might be a little slightly higher, but in the biopsies and excision, usually equivocal cases represent 14 to 15% of all cases. When we do in situ hybridization, it can be done as fluorescent in situ hybridization, chromogenic in situ hybridization, or silver impregnated hybridization, and depending on the laboratory's preference, any of these tests will give you the similar results. The most commonly used in situ hybridization technique is the fluorescent in situ hybridization, and this is conducted by either using a single probe to enumerate HER2 copies per nucleus, or dual probe with a HER2 probe and a chromosome 17 centromere probe to allow the determination of HER2 to Sep17 ratio. And the use of this control probe originally was intended to correct for potential errors in the estimation of HER2 gene copy numbers that could be caused by paraffin-embedded tissue sectioning of the nucleus, especially the truncation or duplication of chromosomes during mitosis. And considering all these technical factors, the definition of HER2 positivity has been changed over the years. When we have the first approval of Herceptin and Hercept test as a biomarker for this drug, the definition of HER2 positivity was either 3+ immunohistochemistry or a ratio of more than 2 with copy numbers more than 4 for in situ hybridization. In the 2007, we used slightly different, and 2013, which I'm going to discuss a little later. And currently, there is a committee by ASCO CAP, and they are working on and trying to change the 2013 guidelines. One of the issues about the 2013 guidelines is that the percent of equivocal cases has significantly increased because in these guidelines, not only the ratio, but we also use the copy number signals per cell, which is more than 4 signals and less than 6 signals per cell as being the equivocal cases. With this technique, copy number is important. When we use the dual probe, then not only the copy number, but the ratio is important. As many laboratories gained more experience with this dual probe FISH analysis, it became apparent that copy number abnormalities, especially the alpha satellite DNA at the centromeric hybridization site of chromosome 17, the HER2 status may be skewed by using this ratio. And the co-amplification of CEP17 and HER2 could be a source of false negative result. As I indicated before, from 2007 to 2013, there was a significant increase on equivocal cases. And when we evaluated more cases, it became apparent that, excuse me, the polysomy 17 is not a very common event. And the increased CEP17 copy number often result from the amplification or copy number gain in the centromeric or pericentromeric region of chromosome 17. So then there were some recommendations to use a reflex, another test, especially looking at the other probes around chromosome 7, maybe away from the HER2 region. And the additional probes have been proposed, and these include SMS, which is also called RA1-1, retinoic acid receptor alpha, or P53, and these are all located in the either P or Q arm of chromosome 17, and they were proposed to use as in contrast to CEP17. And using these alternative probes, it has been shown that approximately 60% of the cases which were originally described as equivocal can be upgraded to HER2 positive status. And the impact of an alternative chromosome 17 probe and using the 2013 criteria has been evaluated by multiple groups. This from a large referral center show that approximately 1/3 of the patients, 26% of the patients using the 2007 and 28% of the patients using 2013 guidelines can be upgraded. And when they looked at the cases which change HER2 status, and 13% of them were reclassified from non-amplified to amplified, and 42% of the patients were reclassified from equivocal to amplified, showing that using these alternative probes, actually HER2 positivity rate is significantly increased. Obviously, we don't have the clinical data in terms of if these patients are going to respond to targeted therapy. And on this diagram from the same study shows that actually these patients, like 14% of the patients have originally equivocal results. Using the alternative probes, this 14% can go down to 5%. From MD Anderson, Dr. Ibrahim and other investigators looked at this use of alternative probes in relation to clinical outcome. In this group of patients, they looked at it, they had 137 equivocal results using the CEP17 probe. And using alternative probes, they were able to reclassify 61% of the patients. But when they looked at the clinical outcome of these patients, there was no difference in 5-year disease-free survival or overall survival. So even though we definitively reclassified the patients, presence of HER2 definitive status did not really relate to patient's outcome. So because of that, now our recommendation is when there is an equivocal test using the CEP17, using alternative probes may erroneously upgrade the patients, and it might not be reliable in clinical practice. And similarly, in the last San Antonio conference, we had the results of the NSABP B47 trial, which is the trial which is a phase 3 trial comparing the adjuvant chemotherapy with or without trastuzumab for 1 year for high-risk patients with invasive breast carcinoma whose tumors are by immunochemistry, either 1+ or 2+, with each fluorescent in situ hybridization negative. So these are HER2 negative patients received trastuzumab. And the main logic behind this trial was actually from the joint evaluation of NSABP B31 and N9831 trial, where there was a dramatic increase in response rate when Herceptin was added to chemotherapy. And this trial, there was a requirement of central evaluation of HER2. And in the initial, approximately 500 patients were evaluated by central testing. There was a difference between the initial results, and then they mandated that before patient goes into trial, the central testing needs to be performed. And afterwards, they did a subgroup analysis of patients who have FISH positive and negative, and then they had approximately 9% of the patients who had FISH and immunohistochemistry negative, And even in this category, addition of trastuzumab had a beneficial effect. And this is a great example of trying to do subgroup analysis when a trial was not really powered to address that question. So based on this, this B47 trial was conducted, and it was a randomized trial with chemotherapy alone versus chemotherapy plus trastuzumab. And when it was presented at this San Antonio meeting, it was very clear that there was no difference in terms of disease-free survival or overall survival with the addition of trastuzumab in these patients. So from this trial, we can conclude that HER2 negative tumors do not really benefit from anti-HER2 treatment. So there is no benefit with trastuzumab therapy in patients who have FISH ratios less than 2. Obviously, this trial was not specifically for HER2 equivocal cases, but many of the patients had ratios less than 2 with 2+ immunohistochemistry. In a similar cohort is just published last month, looking at the clinical and pathologic features of HER2 dual equivocal patients, both immunohistochemistry and FISH, very similar to B47, both univariate and multivariate analyses. They show that the HER2 equivocal cases were very similar to HER2 negative cases in terms of their Ki67, their estrogen receptor, and their response to therapy were also more similar to HER2 negative tumors. So based on all this data, now our key recommendations for pathologists for HER2 testing is that we must ensure that the interpretation and reporting guidelines, we have to follow the guidelines. And we should interpret all the in situ hybridization based on comparison with H&E morphology. If there is any discordance with H&E morphology and FISH testing, we need to do an alternative methodology. If the tumor is dual equivocal, meaning that immunohistochemistry negative and in situ hybridization negative, alternative tissue sample, if it is available, using this can be very helpful. We have a study which we will be presenting at the upcoming USCAP meeting in 2 months. And we demonstrated that 50% of the time we can actually resolve the equivocal cases if we use an alternative tissue in these cases. Testing ISH by alternative probes at this point is not recommended. For the oncologist, we really cannot recommend HER2-targeted therapy if the initial HER2 test is equivocal using only one test, so the alternative test needs to be performed. Reflex testing should be done on the same specimen using the alternative test, or if the alternative specimen is available, then we can use these alternative specimens. And HER2-targeted therapy may be recommended if both reflex and initial testing is equivocal. However, biology and clinical behavior of these equivocal cases appear more similar to HER2-negative breast carcinomas. Additional testing, such as using next-generation sequencing, molecular probe inversions can also be used, but none of those actually have any clinical data yet. So outside the clinical trials, we are not recommending using these alternative testing. Thank you very much for your attention.